Okay, I'm Donna Sanders, and I'm going to be talking about a thyroid agent today, levothyroxine. So let's do a little background on the thyroid. So what does the thyroid do? The thyroid actually is part of the endocrine system. It's located in front of the neck, just below the larynx, and usually you cannot feel the thyroid, and usually it's not visible. So it releases hormones into the bloodstream that regulate the metabolic rate, heart rate, digestive functions, mood, bone maintenance, and brain development. So it also depends on how much iodine you get from your diet in order for it to work properly. It produces calcitonin, which regulates the calcium in the body also. So hormones. These are the hormones that are released from the thyroid gland. So the parathyroid stimulates the thyroid to release T4 and T3, which is thyroxine and triiodothyronine. T3, which is an active. T3 is the active metabolite of thyroxine. So together they are referred to as the thyroid hormones. So hyperthyroidism is usually when there's an overproductive of the thyroid gland, there's too much T3, T4 in the bloodstream. And usually this happens from Graves' disease or inflammation or even a tumor. Hypothyroidism is an underproduction of the thyroid hormone. And this is usually caused from an autoimmune disorder, poor iodine in the diet, which we talked about, or it's caused from a certain drug. So how is hypothyroidism treated? Hypothyroidism is usually treated by a synthetic form of thyroxine called levothyroxine. Well, how does it work? It restores the hormone levels back to normal and reverses the signs and symptoms, and usually this happens in about 1 to 2 weeks after the first dose. If a person is put on levothyroxine, it's usually a lifelong commitment for the dosage, and sometimes it might need to be adjusted according to each person. So per person, they might need to adjust the dose. And then the thyroid stimulating hormone TSH needs to be monitored at least once a year to make sure that the medication is still working. So pharmacodynamics and the mechanism of action. So levothyroxine, which we refer to as T4, is a synthetic form of thyroxine that acts as one of the thyroid hormones. Thyroxine is released by a protein called thyroglobulin, and it's released into the bloodstream, where in the liver and the kidney it's converted to T3, which is again the active metabolite, and this then increases the metabolic rate of each of the body's cells. So thyroid hormones attach to proteins. They're transported to the receptors at the cellular level, and where they enter the cells and go into the cytoplasm and the nucleus of each cell in the body. The levothyroxine acts as a replacement for natural thyroxine, and the deficiency is relieved. The bioavailability is about 80% in a healthy GI tract, and 99% of the drug is bound to proteins. Thyroxine binding globulin, thyroxine binding prealbumin, and then albumin. Those are the proteins that it attaches itself to. So 70% of T4 is converted to T3 in the liver and then eliminated in the urine. And then the half-life of the T4 is about 6 to 7 days, and the half-life of the T3 is about 1 to 2 days. So dosing. One thing you need to know about the dosing of thyroid medication, it's going to be different for each person. Each person's, you have to take into accountability the age. You have to take in the body weight or the BMI. You have to look at, is there any cardiovascular history that we need to worry about. We need to make sure that, if they're pregnant, the dosage might need to be adjusted. And then, of course, if they're taking any other medications that will kind of alter the pharmacokinetics the drug, the absorption, distribution, or whatever. So levothyroxine, the dose usually starts in a healthy individual, and when I say healthy individual, that eliminates the elderly, because they start to decline. Elderly start to decline at a certain age, and they have kidney function decline. So we're talking about a healthy individual. Usually they start a replacement at 1.6 micrograms per kilogram per day, and so 100 to 125 micrograms per day for a 70 kilogram adult. So adjustments may need to be done. And that's why usually when this dose is started, they will they'll do it for about 30, they'll start you on a 30-day supply, and then after 30 days, they'll check the blood again, and then maybe adjust it in, and if it's holding where they want the blood levels to be then you might not come back for 6 months to a year. So if it needs to be increased, the recommendation for increasing the dose is 12.5 to 25 micrograms increments every 4 to 6 weeks until the THS levels kind of run or return to normal. So back to the elderly. Now we know, at a certain age they start to decline, like I said before. So we have to increase their dosage a little slower. It's because their results are going to be different. And it might take longer to get the results. So just make sure that if the elderly are being dosed and they need an increase, to do it more slowly. And then it shows you here at the bottom what this drug what it comes available in the microgram tablet. So it ranges from the 25 to 300 microgram tablets. What are the adverse reactions? Usually the adverse reactions are due to overdosage. So, and generally, if there's going to be adverse reactions, there's going to be like fatigue, weight loss, heat intolerance. And so you can see that these, in a minute when we talk about the side effects it's kind of the same as not taking the drug or taking too much of the drug. So fatigue, weight loss, and heat intolerance, these patients might have this without the drug, so maybe the drug's not working. So these are kind of some things that you might want to think about when you're looking at the signs and symptoms. So generally, if there's going to be a reaction, it's fatigue, weight loss, heat intolerance, maybe increased appetite, fever, or excessive sweating. And then, of course, they list some CNS and musculoskeletal, cardiovascular. It might cause some palpitations or tachycardia. If it's a severe overdosage, the patient could have an MI or go into cardiac arrest because it does increase the heart rate in the patient. So GI, there might be diarrhea and vomiting or cramps, elevated liver function tests, so the liver function might need to be monitored. And then, of course, endocrine, decreased in bone mineral density, and then the reproductive menstrual irregularities and impaired fertility is an adverse reaction. But going back to the adverse reaction, it's very uncommon. I know one article I read said that it's very rare. Usually if they start low dosage, they can catch these before any of these adverse reactions really cause a problem. So interactions and contraindications. The metabolism of levothyroxine can be altered with other medications. So you have to be very careful and monitor any medications, other medications that the patient's on. So the absorption is usually the part of the altering that's done with this medication. Absorption with food, so this medication needs to be taken on an empty stomach, and it should be taken about 30 to 60 minutes before breakfast. No iron or calcium carbonate should be taken within 4 hours of levothyroxine because it alters the absorption. Soybean, walnuts, foods high in fiber and acids will decrease the absorption. So just make sure that you talk to your doctor about any medications that you're taking, and that you're well educated on when to take this medication and what you can take it with. And that is the references there. I hope you enjoyed my presentation. Thank you.